بسم الله الرحمن الرحيم، وبه نستعين استكمالا لموضوع المال روتيشن. وما أدراك ما المال روتيشن. شرحنا، عايزين بقى نبتدي نحل، والحل هيبقى عن طريق الكتاب العظيم بتاع دكتور شريف إيميل بتاع الكلينيكال بيزد ستادي. طيب تعالى معايا كده بقى، شوف معايا ما روتيشن اند ميد جاد فالفلس. نبني على الكلام اللي فات بقى، يعني راجع الحلقات السابقه كلها حلقات 10 دقائق 15 دقيقه 12 دقيقه كده يعني. نبدا بقى في الكيس. طبعا هي مش كيس، يعني هي مش كيس، هي كيس بيتفرع منها تفرعات كتيره قوي. هتلاقي ان في اخر الكيس بيكلمك على النون روتيشن والريفرسد روتيشن وقصه كبيره ما يعلم بها الا ربنا. So we'll start with the case stating that there is a 9-year-old. This is not the typical age. The typical age is around the infancy and neonatal period, but actually the 9 years, 7 years, 6 years is an age of negligence or skipped symptoms. He said 9 years old and wait a minute, a 9 years old boy with chronic abdominal pain and vomiting, and the vomiting is actually bilious. You will see with no significant past medical history. Okay, is referred to the clinic for 1 year history of intermittent abdominal pain. I'll talk in English because many of our audience are asking for that. They are not from Arabic region, and it's total hassle to make captions and translation for that. The episodes were rare and mild. The episodes were rare and mild. What are these episodes? Intermittent abdominal pain and vomiting. Over the last 6 months, they have increased in frequency and severity. Increasingly abdominal pain and vomiting. This is vomiting here stated now. The emesis often consists of previous meals. He didn't say it is an bilious emesis, but actually when these meals are evacuated and you reach the point that the stomach is empty and vomiting still occurs, this means that there is obstruction still by Lad's band or by the volvulation. We told you before that the obstruction has 2 causes in the malrotation. First one is an obstructive cause of the duodenum, which is due to Lad bands between the duodenum and the colon, and the second cause is the volvulation of the stomach, which is not a must to be accompanied by the ischemia, but has been dark green on a number of occasions. That's what made the parents seek medical help, including the week prior to the clinic visit. Over the past occasions, including during the week prior to over the past 3 months, his stool has been found to be frequently loose. This is an indicator of malabsorption. Diarrhea may be malabsorption, may be steatorrhea. This is due to the lymphatic obstruction due to volvulation, which leads to lack of absorption of the fat. So take care here. Every point has a significance. Frequently loose, foul smelling, and floating in the toilet. Floating means it's fat, it's like the oil. Proton pump inhibitor was commenced and by the pediatrician with no improvement of the symptoms. Examination. No distress, vitals normal, 30 kilogram, which is within the normal. The abdomen is low normal. The abdomen is entirely soft, but he said non-distended. So the first important is the vomiting that turns bilious. The second important is the non-distension, and the third important is frequently loose stools that have the character of being foul smelling and floating. There are no palpable masses or hernias. He is excluding other common causes. An abdominal serous, which is UGI serous, which is abdominal serous means with plain X-rays, has normal gas pattern. The normal gas pattern in the abdominal X-ray is not excluding malrotation. It may be showing abnormal distribution of gas, and it may not. Electrolytes, albumin, prealbumin, and complete blood count are normal. What's your suspicion? Here we want to ask an important question, which is about the bilious emesis. Bilious emesis in a neonate, in an infant, in early childhood, in late childhood, must be taken in consideration as a surgical case. You must make the pediatricians, the general pediatric doctors, and the general ER doctors aware that any bilious emesis is of surgical significance until proved otherwise. I'll give you highlights along the text. He is not malnourished. He is explaining for you. His examination is normal, and laboratory tests are and abdominal films, plain X-rays, are normal. However, the symptoms are extremely concerning. Bilious emesis, which is the main symptom with the abdominal pain, but bilious emesis is frustrating and what made the parents come and seek help. Whether acute or chronic bilious emesis, whether acute or chronic, is never normal, is never normal. This is a very important highlighting in this context. Bilious emesis, whatever is chronic or acute, is never normal and should be investigated electively or urgently. In addition, the description of a stool means that there is steatorrhea due to fat malabsorption. Fat malabsorption doesn't mean malrotation, but means gut congestion, lymphatic obstruction. This constellation of symptoms is quite suspicious of chronic midgut volvulus. As usual, there are many medical causes, but we should exclude the surgical cause. Any doctor knows that. Any surgeon, any internal medicine doctor, any pediatrician should know that the surgical cause should be excluded, and then we proceed with the patient in the other causes. Because the most dangerous and the most life-threatening should be excluded first. Secondary to malrotation. He said volvulus and didn't say malrotation because there are symptoms of congestion. This means that there is ischemic obstruction. And what's the next step? The gold standard, remember with me, the gold standard is not the ultrasonography and the duplex to show the relation of superior mesenteric artery and vein, but the gold standard remains till now to the up-to-date information about malrotation is UGI serous, which means upper gastrointestinal contrast. While it's not an acute presentation, the study should still be performed urgently. And what's meant by urgently, it's not after half an hour, but it is within 24 hours it should be done. The sooner, the best, given the suspicion of malrotation. After requesting UGI study, you received a call from the pediatric radiologist. He reviewed the plain films. He said that the plain films are normal. He doubts the diagnosis of volvulus. He's not sure, and asks if he can perform an ultrasound instead to screen the patient. You can make the ultrasound, but it's not sufficient, meaning that if you found the ultrasound there is no abnormality in the relation of the superior mesenteric artery and vein, that doesn't mean that you will not proceed for UGI contrast series. So that means that the gold standard remains the UGI contrast series. To know about the superior mesenteric artery and vein. Superior mesenteric artery should be medial to the superior mesenteric vein. The one is medial is artery. The one is lateral is the vein. In the first 3 centimeters of the origin of superior mesenteric artery. After that, after these 3 centimeters that the radiologist look at, but if he looked after these 3 centimeters, it's normal that they are reversed and the vein becomes medial. But the vein is still lateral and must be lateral to the artery in the first 3 centimeters of the origin of the artery. So what's the diagnostic criteria is the reversal of this relation. The superior mesenteric vein becomes medial to the superior mesenteric artery in the first 3 centimeters of their origin. This is the normal anatomy. The vein should be lateral to the artery. It becomes medial in the first origin. So this means reversed relation. Doubts diagnosis of volvulus. Okay. Ultrasound is increasingly being diagnosed. The radiologist assess the relationship of the superior mesenteric artery and superior mesenteric vein. The suspects malrotation if the relationship is reversed, which means that the superior mesenteric vein is medial to the artery. And I told you that it should be lateral to the artery in the first 3 centimeters. And this is called the whirlpool sign. It's like whirlpool, and it's done with the arteries and also the fat around and the mesentery. Issue here is the dependability of the ultrasound. It's not sufficient, which is operator dependent. This is the first disadvantage, and the surgeon will do it with positive or negative results. Will a positive result prompt surgery? Will a negative result exclude surgery? This is not right. The UGI contrast study is the most important. Ultrasound is not still the gold standard. Despite this limitation, the patient is not persisting acutely and the time is not a factor. This is very accurate words from the author. As long as the radiologist ultrasound understands that a UGI series, the radiologist understands that the UGI contrast series will still be required, an ultrasound can be performed in order to help us to diagnose. Okay, or to reach a diagnosis and serve with ultrasound for this indication and serve as a quality control. It's important for institution-specific step toward using ultrasound reliably for the diagnosis of malrotation and volvulus. And he told you about the superior mesenteric artery and vein relation here. You can see this is the artery, this is the aorta, this is the vein. Here this is the artery, this is the vein. It's not a must for you as a pediatric surgeon to understand the ultrasonographic picture. Even me, I do not know where is the medial and where is the lateral here, but it's sufficient that he tells you there is a reverse relationship and the superior mesenteric vein becomes medial to the artery in the first part of its origin. Vascular relationship, whirlpool sign. The duodenum does not make a cross C loop or cross the midline. The first regional loops are to the right of the middle line in a corkscrew pattern. This is the contrast findings. So the ultrasonography used duplex has the reversal of relationship between artery and vein. And then this is the corkscrew. This is the esophagus and the gastroesophageal junction, then the stomach. And after the stomach, the duodenum C curve is delineated. And then it does not, the DJ, the duodenojejunal junction, does not cross the left pedicle of the vertebrae, but it actually is on the left border of the vertebra and making the corkscrew appearance like here. This is the corkscrew appearance, which is narrowing of the DJ junction and obstruction at this point. No complete rotation happened, or no complete fixation happens. I told you that there is a large spectrum in So you book for a LAT procedure after corkscrew appearance and not crossing the midline, and also after the ultrasonographic appearance. We will continue in the next session for the operation. So the case study, this is the first episode in it. Thank you.